This is the easiest way to interpret an ECG in 3 minutes. Let's start. Look at the rhythm. Are P waves positive in lead 1 and 2? Is each QRS complex preceded by a P wave? Are the pair intervals constant? If all the three are satisfied, then it is sinus rhythm. Then look at the rate. Rate can be calculated by using this formula: 300 by number of large squares in an RR interval, or 1500 by number of small squares in an RR interval. Rate more than 100 is sinus tachycardia, less than 60 is bradycardia. Now let's look at the P wave. At lead 2, if the P wave amplitude is more than 2.5 mm, then it is right atrial enlargement or P pulmonale. At lead 1, if the negative portion of the P wave is more than 1 mm deep or duration more than 40 milliseconds, then it is left atrial enlargement, P mitral. At lead 2, if there is a bifid P wave whose peaks are separated by 40 milliseconds or the entire P wave duration is more than 0.12 seconds, again it is a left atrial enlargement. Now let's look at the PR interval. If it is more than 0.2 seconds, then it is prolonged, seen in first degree AV block. If it is less than 0.12 seconds, then it is short, and if there is a visible delta wave, then it is a WBW syndrome. Now let's look at the QRS complex. QRS complex can be remembered by using this mnemonic ADAM: axis, duration, amplitude, and morphology. Axis: lead 1 is up, AVS is up, normal axis. Lead 1 is up, AVS is down, lead 2 is up, still normal axis, but it is 0 to 30 degrees. Lead 1 is up, AVF is down, lead 2 is also down, then it is left axis. Lead 1 is down, AVF is up, then it is right axis. Lead 1 is down, AVF is also down, then it is northwest axis. Duration of QRS complex more than 0.12 seconds is WBW syndrome. 0.12 seconds with M in V1, W in V6 is RBBB. More than 0.12 seconds with W in V1 and M in V6 is LBBB. Now amplitude. If S in V1 plus R in V5 or V6 amplitude is more than 35 mm, then it is left ventricular hypertrophy. If R by S ratio in V1 is more than 1 or R by S ratio in V6 less than 1, indicates right ventricular hypertrophy. If the QRS amplitude is less than 5 mm in all the limb leads and less than 10 mm in all precordial leads, then it indicates low voltage QRS complexes. Now morphology. If there are any pathological Q waves, it indicates MI. Pathological Q waves means more than 1 mm wide or more than 2 mm deep. Look at the ST segment. Depression seen in NST elevation MI. Depression with the features of LVH, RVH could be because of the strain pattern seen in hypertrophy. ST elevation with concave upwards and seen in all the leads, the cause is pericarditis. ST segment elevation with convex upwards and seen in specific leads with reciprocal changes in the opposite leads indicates ST elevation MI. Then T wave. Tall T waves, narrow base, pointed peak, hyperkalemia. Broad base and rounded peak is called as the hyperacute T wave seen in acute ST elevation MI. T wave inversion, then it is NST elevation MI. Lastly, look at QT interval. Short QT, QTC less than 350 milliseconds seen in hypercalcemia. Prolonged QTC can be seen in hypocalcemia. Tall T wave, hyperkalemia. U wave, ST depression, T wave flattening, hypokalemia.